So I'm really pleased to be joined today by June Green and also pieces here from the Caribbean and African Health Network, and they're going to June is going to be talking to us today about targeted engagement for increased vaccination uptake. So I'm going to pass over to June now, who's Health Liaison Practitioner at CAHN. So thank you very much, June.
Thank you very much. As Eloisa stated out, my title is Health Liaison Practitioner for CAHN, and I've worked with CAHN, started in 2017 volunteering and been in a paid role for the last couple of years. Background of nursing and midwifery for over 40 years, and I retired from the health service just before I started the paid role for CAHN. So I'm working with them on different projects, work with Peace a lot as well. And I'll just share my screen with you. Okay, I'm hoping that everybody can see this, because while I'm doing this, can everybody see my screen and you can hear me clearly?
Yep, all good. All good, yep.
Okay. Right, so I'm going to do, it's a twofold talk this morning, and we're going to talk about, I'm going to start off with the winter 2022 vaccination programs that CAHN did. So the first part of the slides, there's some of me in it and there's some of what happened, and then I will then go on to nurses screening, just what else we do, because that's just another service that we offer. Okay, so we're going to be talking about an introduction about CAHN, its vision, missions and values, and why we were set up, and CAHN's objectives, structural barriers. Then we'll talk about I've put in a bit about COVID and previous vaccination activities, and the winter programme, and the Frimley Integrated Care Board, as well as Salford vaccination clinics and the national social media campaign. So I know Peace had done this, but I know for this purpose we'll do this. CAHN's vision, and I think this is what really attracted me to this organisation, is to end health inequalities and wider disparities for Caribbean and African people in a generation. And our mission is to ensure that the strategic and operational actions for service providers and commissioners across health and cross-sector agencies lead to racial and social justice for Black people. It's just such an amazing thing to be a part of. So these are our objectives. So for CAHN, we work collaboratively with Caribbean and African faith. There's over 82%, research has shown over 82% of Black, African and Caribbean people in this country are religious, are actively religious. So it's important to work collaboratively with the faith and community organisations to strengthen their structures and systems so that they can be responsive to meet the health and well-being needs of the community. That is really important that we do that. Build partnerships across sectors, and to be the point of contact between communities, voluntary sector members and commissioning agencies. So with that link, engage in continuous consultation, planning, evaluation to provide solutions to persistent health inequalities and act as a direct point of contact with commissioners, and to champion the work of the Caribbean and African community and promote its assets, efficiencies and achievements. And we do this by using different platforms like health programs, media policies and influence, membership and support, and education and research. Why CAHN? I mean, there's lots of organisation out there, so why do we choose CAHN? The huge problem is the poor access to healthcare, to everything, and that's down to lack of trust, which then creates poor engagement, because if you don't trust somebody, you're not going to engage with them. Inadequate knowledge of research, bias of structural system and processes of practice. So because there's inadequate knowledge of research, there's a bias of process and practices. I worked in research for many years, and there's an obvious bias because of the Black community not trusting research. And I can't blame them, because the history of being put into research without their consent and all sorts have been done to the Black population. I'm not surprised that they don't want to engage, but it then creates a problem of a lack of information, knowledge about our community and what we need as a people, because our health needs are different. So this leads to structural barriers. So decision making and representation, benchmarking to majority populations, just as I said before, when drugs, for example, are researched and there's not enough Black people taking part in the research, the benchmarking, what works for them is based on the people who take part in the research, which are very rarely the Black population. Sometimes when researchers are putting out the call for the people that they want, the criteria, they sometimes say English speaking only, which I suppose for them it's too expensive to translate the documents, but also it means it cuts out a huge majority of people, especially those who might need the specific medication and maybe slightly titrated in a slightly different way so that it can be more effective in our community. So we need to look at the benchmarking, because it's not our benchmark. Racial discrimination, unconscious and conscious bias. Some people will say there's no unconscious or unconscious bias, it's just bias. Poor engagement and investment, especially in the faith sector. So everything they do in the faith sector, they try and help the community, but they are limited by funds because there's very little investment. This is the organization sustainability. So this is how CAHN work, how we work together. We work with strategic collaboration and partnerships, and national, regional and local influences. So it's not just, we're based in Manchester, but we're all over the place. Products and services, and we have a lot, and community engagement. So we have a lot of different departments. Areas of work. So these are our main areas of work. We've got teams in CAHN for all these particular areas. So there's a community engagement and empowerment team, health and wellbeing services and projects. I work in that team. Education, training, leadership development, organisation development and capacity building, and research and innovation. And all these together, we're hoping is going to eradicate health inequalities and disparities. So it's not just one thing doing it in one way. All these together, every brick in that circle has got its place. One of the things that attracted me as a nurse was the health priorities. So there's cardiovascular, cancer, mental and emotional health, respiratory condition, bloodborne and immunological conditions, and reproductive and sexual health. Now, these areas are the areas where we as a community do not do very well in. We have less access to healthcare and tend to be less represented in these areas and have poor access. So these health streams, the way CAHN's focused on working in these health streams to make sure that we can improve the access and health literacy. Okay, so why was COVID? Why was it such a nightmare? And one of the things I thought about was, well, I looked at the factors that make us Black and African Caribbean people more susceptible to COVID-19. And I felt it was important to look at that because, we did a lot of work with that, but this is just some background why it was such a shock to the community, why so many of us died from it. And it's the people in they all over the world have been observed to be disproportionately affected by COVID-19, and several factors contribute this. to this increased susceptibility. There's socio-economic disparities, for example, more likely to be working in essential frontline jobs and live in crowded housing and limited access to healthcare resources. It's not unlimited, it's limited access to healthcare resources, and that could lead to higher exposure to the virus. Pre-existing health disparities, which is a huge one, such as higher rates of underlying health conditions like hypertension, diabetes, and obesity within these communities. Healthcare access, like I said, can be limited in these communities, which results in delayed or suboptimal care for COVID-19 patients. For example, when people say, what does it mean, healthcare access? Somebody recently, a colleague of mine, was ringing up because she was unwell and she'd found these lumps under her arms, wanted to access. 45 minutes she had to wait to get through to the GP, but she knew it was important, so she waited. And also, it was, if you think about most jobs, most people are working, and I know with my GP they said ring at 8 in the morning, so you could be sitting on the phone for 45 minutes. That's not always possible, so a lot of people would have given up and just not tried to get through. Multi-generational households, which can facilitate the virus to more people in the family to get the virus. So that's one of the things that we needed to, that's another problem, another factor. Cultural and socioeconomic factors may influence behaviour. For example, relying on public transportation or densely populated areas can make social distancing difficult. Discrimination and stress. Experiences of racism and discrimination, it is proven. There's lots of research out there. Discrimination, stress, experiences of racism and discrimination can contribute to chronic stress. I'm just pausing there because it doesn't sound like much, but all these points are things that we've also found in our research. There's numbers to back it up. And it's so interesting that, you know, we take it on board. And these discrimination and racism, it can contribute to chronic stress, but also it contributes to other illnesses later on in life, or we get them earlier, things like diabetes and high blood pressure. All these can be affected by the discrimination and chronic stress. And which inevitably there was a huge vaccination hesitancy or mistrust of healthcare institutions, and that's a huge barrier. And if you listen to everything else I've said, it kind of makes sense that they're not trusting in healthcare, they're not getting access to healthcare. In the past, they've done loads of experiments and done research without our consent. So, and they can't even access healthcare. So why are they going to suddenly trust this miracle vaccine? And on top of that, look how many of us were dying from it. So it was a huge effort to try and get some people to be vaccinated to make, stop us from dying, to prevent it, to slow it down. We still don't know the exact factors, but if you think about it, when you first heard about COVID-19, the factors that you were seeing, the people that you were seeing on television, the nurses, the healthcare professionals, were mainly black or brown people. They're the ones that died first, and all these factors come into play. So if you're sitting there watching all these things, and then suddenly in a few weeks, because in research, these things, most research takes years. I'm talking between 5 and 10 years for the full research to be done. And then they were coming out with this vaccination within a few months. It makes sense why people didn't trust it, because we were still dying from COVID-19. So the Frimley Integrated Care Board, the ICB, gave CAHN, they asked us to do to find out, do a bit more work around it and let us know what's going on, what can they do. So they wanted a targeted community engagement. So they gave this to CAHN to do, a commission, and they wanted to find different ways really to re-engage the Black community. So there was social media, Twitter, Facebook, and Instagram. So the campaign lasted between October and December 2022. targeted community engagement, in-person and webinar engagement in the Black community, and to get them to understand their experiences. So we're asking them what's happened to you. Creating infographic and e-postcards with community and faith leaders. There was health talks, inviting health professionals to deliver dedicated engagement sessions, and faith leaders engagement to address faith concerns about COVID-19 and vaccine. So they were meeting. So what CAHN did was meet with all these different factions of the community that were just as important to get the message out there. So they spoke to the community and said, you know, what's your experience? Why don't you want to take the vaccine? What can we do to make you feel more comfortable? And health talks, they used Black health professionals. So people were more likely to respond to somebody who looked like them. Culturally appropriate assets aimed at the community WhatsApp groups, and COVID-19 vaccine helpline to support any inquiries and refer clinical queries accordingly. So those were the things that they did. They set up these helplines so people could ring if they were anxious, if they wanted more information, and they also did health hours where they would get professionals talking about, and people could ask questions. They could ask senior physicians, what do you think about it? Or ask whatever was worrying them, they could ask them about it. We set up Salford vaccination clinics in Salford. There were 6 clinics, 4 in December and 2 in January. And instead of setting them up in remote places, we used community centres and churches. So places that people were familiar with, places that they trusted, and we used CAHN, which was, we did some, I think Peace talked about it last week, which was a project we did where we actually got people from the community and we trained them. There were business owners or church community leaders or barbers and hairdressers where Black people would frequent, the places where they would frequent most, and community leaders. And we taught them about health. We gave them a bit about information about health literacy and the different conditions and how they could support people who came in and spoke to them. So we used one of the churches in Salford as they actually had it was a very nice day. They had food as well. Food's always welcome. So they had food, and we had people come in and we talked to them about vaccinations, and then we set up a station there. So then they chose if they wanted to go ahead and get their vaccinations. They came up to us as nurses and we gave the vaccinations. So the provisional dates were being discussed with identified venues, and we used publicity and social media telling people this is what's happening. Door knocking. We went around in the areas where there was a dense population of Black African and Caribbean people, knocked on the door and spoke to them, gave them information. This is what we're doing. This is where we'll be. If you decide to come along, then please do. Volunteers and staff to support as marshals. So we had our CAHN volunteers there who were helping them when they came in. This is where you go, and then you go from this post, you give your information in. And engagement with Salford Black leaders and Salford church leaders was important. It was essential to get the information out there. And support and promotion of Salford City Council themselves were very helpful, and the Integrated Care Partnership. So we got nearly everybody involved who we could, because there were a lot of GPs, primary care networks who couldn't get people to come in and get the vaccination. So this was a way of doing it. So rather than having the dedicated vaccination centres, we had pop-up ones. Even in shop, we're in a shopping centre for a couple of times, and people were walking past and we're saying, have you had your COVID vaccine? And them come in and talk to us. We did that a couple of days in a week. So then there was a national online vaccination Christmas campaign. So they used new or existing content creation. So what we had, we maybe made it, tweaked it a bit. And the campaign went live from the 1st to the 10th of December 2022. And the promotion of the CAHN helpline, so people knew that they could ring us and talk to us about things. And we used the health hours, like I said, on Saturday, and Salford clinics and other CAHN events to push the message across about giving the people. At the end of the day, it was their choice. But if you can make an informed decision, that's got to be better than a decision based on fear or no facts. So if you gave them the information, you gave people the information, gave them the opportunity to talk about it, then it's up to them. That's all you can do, is encourage them and their family to decide, make a decision whether they were going to have the vaccination or not. And if they said they didn't, you could talk to them about it. At the end of the day, it was their decision, but we just wanted to improve that, give them better access to that. So we co-produced up to 8 health stories in a suitable social media format, featuring trusted Black health professionals, and we're able a patient to build trust and confidence. So that was one of the methodologies of engagement. So I've seen one of the stories online where they spoke, somebody was saying that he's a community leader, and I think a lot of people know him in his area, and he was saying that he chose to have the vaccine. He was fine afterwards, and he just wanted to share that, saying to people, don't worry about it, at least it keeps you healthy. And share these stories organically in the social media channels and boost one post. I remember one person talking to me and saying, or talking at a meeting, and lots of people going, I'm not having it, I'm not having it. And this person stood up and said, I wanted to protect my elderly relatives. Because remember before I said about one of the factors is that sometimes we live with multi-generational, so the older people are more vulnerable. And he said, I had the vaccination because I wanted to protect my elderly relatives. And that was something that struck home. So he said it wasn't, he said he felt it would have been selfish because he was going out to work, mixing the community, and he didn't want to make his parents, who were already vulnerable, more vulnerable. When he went to see them, at least he felt he had the protection of the vaccine. So we had a series of positive NHS stories, screening and immunisation articles that promote COVID-19 vaccination, and share the contents, that the NHS, England and regional teams, share it with them and our partners via networks, website and social media platforms. So the message was out there, up and down the country, at least get your information right, get your facts right if you're going to decide, so you can make an informed decision for yourself, for your health. So these are the takeaways that they would say to people. Do you know anybody, any individuals, community or faith leaders in Frimley, and any Black-led organisations or business operating? So what they did was they put this out in the area. Do you know any clinicians, especially doctors living in Frimley, Salford clinics, where the dates are circulated, cascading to your team members, and encourage participation as marshals and volunteers. So many of us who look like us, who were able to do that, we got them out there in the cathedrals. We were everywhere, and people knew we were there. We put the publicity out and share the messages with your contacts via social media networks, especially WhatsApp, Facebook, Twitter, LinkedIn, everything, all those social medias, and consider including the campaign information in your signature block. So when we send emails out as an organization, we put the campaign information in there as well, so that people were, they were given the message on many different formats. Okay. Now, this second part, because I said this was like a story in 2 parts. This was just something else that we did, that we continue to do, as an organisation, reaching out to the community and still working on the same basis of improving health equality. We want people to know about their health. So it's just a few more slides that I can tell you about. I'll tell you about what we do as a nurses screening. As I said before, I'm a nurse by background, over 40 years as a registered nurse. So it's been amazing to be able to still use my skills in CAHN, and this is what we did. I'm just going to tell you a little bit about who we are, why do we do it, and what do we do, and how do we do it. That's us, little picture. And there's a bank of us, and we volunteer as registered nurses, and we've got pharmacists, student nurses, health workers. Not enough, but we've got some there. And sometimes other volunteers in CAHN will help us when we're doing our screening. So we've got our banner. So we go into these places and we set up. So there's myself and some of a couple of my colleagues. And what's interesting about us is that we met in the same trust. And even though, I still have quite strong links, even though I'm now retired, but we're doing different things. Like the lady sitting down with the hat on, she works in the community. The lady standing up in the red t-shirt with her head down, she's the lead nurse for the ED in this trust, for the emergency department. So, and there's another one who works in our team who looks after the students, and she's also that's her background as well. She looks after the students. And when we go to these, the reason why I like going to these things, because we can give information, I'll tell you about that in a bit, but the reason why I like going to these things is that when you're there, we're back to basics. We're doing our blood pressures. I mean, I can even remember 40 odd years ago when we were first taught how to do blood pressures and the significance of it. And we can do things and share this information and go back to basics so people understand about their health. This is just our way of giving back. So why do we do it? It's because hypertension is a leading preventable cause of heart attack, stroke, renal disease, and ultimately death. 1.28 billion adults with hypertension worldwide, that's how many there are, and 80% of those, they don't have hypertension under control. And in the UK, that's less than 1%. And the prevalence of hypertension in Black people is amongst the highest in the world. I know these figures and I've read them before, but every time I feel so humbled when I read them because it's startling. Black, African and Caribbean people are 4 times more likely to have hypertension, high blood pressure, 2 times more likely to have a stroke, and 3 times more likely to have type 2 diabetes. And not only that, but get it 10 years younger. That's the same with the hypertension. That's getting it 10 years younger. So when the national screening, when you go to your GP and they start screening at age 50, sometimes we've already had it for 10 years as a community. And it's sometimes getting it younger. So there's young people walking around, they don't even know. We've tested staff members, we've tested, we've gone out and we've tested in the community, and we've had people like close to home. You've just said, it's quiet, there's nobody here, come and sit at my store, let me do your blood pressure. And recently there was a colleague whose blood pressure was high and the blood glucose was high. And these people ended up having to get further care. So this is what we do when we set up camp. We test the blood pressure. If it's abnormal, we do it 3 times. So we've got an average number. Sometimes people are just anxious about it. And we do the heart rate or pulse, temperature, blood glucose. We test for atrial fibrillation, which I'll talk about in a bit. And what we do is we promote health literacy and we give advice. So we don't just do the blood pressure, say, oh, it's high, go to your GPs. We do that, but we get to talk to them. So we can talk to them and say, your blood pressure is not high yet, but it could be, for example, it's getting there, you're pre-hypertensive or pre-diabetic. And these are the things you can do to avoid having to get to level, excuse me a minute, where you have to take medication. So we can give them information, culturally competent information. We can talk about, these are the things you can change in your diet. These are things that you can do. We can refer them to we have a Healthy Hearts meeting on a Tuesday afternoon, and we have a nutritionalist who talks to us all about cooking food healthier in our community. So it's the same food. The biggest message is that you do not have to give up your food, your food, because our food is made for our bodies, what we're used to. And I think it's so important that people understand you don't have to give up your food. All you need to do, sometimes it's tweaking it. For example, plantains. If you fry it, obviously it's a lot higher in calories and carbs, where you could steam it, cook it in the oven, use less oil, simple tweaks like that so you can still eat your food. So it's important. Sweet potato, that's better for us than normal than white potatoes. So we give that information out. We talk to them and we show them these are the Caribbean versions of things. I remember 40, 50 years ago, 40, 50 odd years ago now, and when my relatives were coming home saying, yeah, coming back to the house saying, yeah, they've told us we're diabetic and they're giving us this, and they'd look at this piece of paper with the diet sheet and they'd say, what's that? And they'd sit there laughing at this food because they had no idea what it was. But they would just sit there when they were told about it or seen a dietitian, they'd just go, yes, okay, yes. But there's no way they could stick to that diet. We didn't even know what the food was. So hopefully nowadays we've moved on and that we're able to give them culturally competent food that they can still eat. Just change the way you eat it. And it has a public health effect in the case of if they cook better, they eat better, their family will be healthier because that's the way their children will grow up cooking and understanding this is what we need to do. So there was a family a few weeks ago, both parents had high blood pressure, yet they were still cooking these, these huge foods and having quite big portions. So that it's not, even portion control, just having a little less, smaller plates, little thing that you can tell them about that and say, you don't want your children, and they don't. If you say, well, if you don't want your children to end up with these conditions, then you need to look after both of you. You have to look after yourselves. So this is what we're teaching people to do. So we take some graphics. We use we have a tablet. So when we can, but I'm fighting with nurses, and some of them they said we like the paperwork, but we try and put as much in as we can, and we get basic stuff like date, initials, gender, postcode, ethnicity. So we just ask for initials. So we don't need too much information. It's just for our paperwork to say, yeah, this is that person's, and then we ask them for ethnicity. And then I ask them about the medication. Are they taking, obviously we take the blood pressure, pulse and everything else. Ask them what medication they're taking. And if they're taking some, have they taken it today? And we do blood glucose. We can do the atrial fibrillation, which is using a little cardio machine, which I'll show you in a minute. And the reason why we out of all the things random, it might seem random, but with atrial fibrillation, it's a particular the heart isn't beating properly. So instead of just beating contract, relax, contract, relax, with the atrial fibrillation, it'll contract and then it'll just do that. That's as it sounds, fibrillate rather than beat properly. And this can cause lots of problems in the body, as you can imagine, because the blood's not circulating properly. So it's a rhythm that can cause a lot of problems. So I'll show you, we use gadgets. I like gadgets. So we use a little gadget for that, which is really good because it gives a 30-second ECG, and I'll show you that on the next slide. We talk about lifestyle advice. We give them, I've got loads of leaflets. I carry them around. My car's full of them. We talk about, but I don't just give them a leaflet. We talk about lifestyle advice. So we're saying, find something you like to do. If you get out there, exercise, walk a bit more. Get out with the kids when they go to the park, walk with them to the park, walk back, don't just drive them everywhere. So you're encouraging that the children will be healthier too. Walk out in the countryside, dance. If you like dancing, dance 3-4 times a week, give yourself half an hour, move about, just keep moving. And we talk about, obviously I've talked about food and stress. And stress isn't an easy one to manage, but even just being aware of it, sometimes it's easier just to say, well, okay, I know that's possible, but this is what I'm going to do, and that kind of thing. So that's what we're doing. And we collect the data, like I said, we use tablets, we collect it digitally when we can, but sometimes we don't always have Wi-Fi, so we tend to write it down, and then I've got to download it. But hopefully, and ideally, we collect it digitally. Right, so this is what I was talking about, was the cardio machine. So right in front of, so this gentleman, this policeman, was our last one of our events, and so I was going to do his test for atrial fibrillation. So that little thing in front of him, with, you can see he's just about to put his fingers on it. So you put 2 fingers from one hand, 2 fingers from the other. So that little square thing on the table in front of him, that's got 2 raised silver, little thing like that, 2 raised silver sides and black in the middle. So I have the app on my phone. I put it near there, and then you put your finger on for 30 seconds, and it does a 30-second ECG recording. So ECG, when you go to the hospital and they do electrocardiogram, and it's 12 leads you use around your body and your arms, your legs, they stick those on. This does this in 30 seconds. and put your fingers on these and you do a 30-second recording of ECG, and then it will say normal, normal sinus rhythm, or it might say, I've only seen very rare, like it said atrial fibrillation has been detected, but it's a good indication about it. But it also gives you a chance as well to talk about all the different things. So that's our table full of stuff. And right at the front there, you can see our food. We have this, they give you these food guides, food wheels, or they tell you about what these are the things that you should and shouldn't eat, but this is an Afro-Caribbean one, so it tells you about our food. So it shows you you have this portion of that portion of this, and it relates to us, so it makes it a bit easier for people to think about things. They also have a book that helps people look at things and go, it gives African Caribbean meals, it gives African meals, it gives Caribbean meals and South Asian meals, and it says if you have, and it goes through our common meals, say like curry, goat, and rice, and if you have this proportion, that's so many carbs, and this is all the different things, so many carbs and this and so many calories, and then it shows you how much sugar is going into your blood from this particular meal, because as you know, you get sugar from savory things as well. So those are the kind of information that we're getting, and that's what keeps me going, is talking to people, giving them information. And it could be anything. It could be anything that you end up talking about. You just never know. Mental health, you start talking about stress, and people just open up to you sometimes, because you're a nurse as well. And plus, I'm nosy, and I ask them, what's going on? Are you okay? This and that. And then people just find it sometimes easier. How do we do it? We go almost anywhere. We go to, we've been to the first event we did was at the first Windrush festival we did was 2017. We just rocked up. We got our equipment. We were also joined by that day by district nurses as well. That's when I first saw the cardia, for atrial fibrillation, and it was brilliant. We just sat there and the sun was shining, and we went to the carnival, and people came up and we checked the blood pressure, talked to them about all these different things, and it was just an amazing thing to do. We've been to church events, cathedral. Every year we rock up at the cathedral for CAHN's launch of the Black History Month, and we sit in the corner and we take blood pressures, pulses. We do that and talk to people. The Yam Festival, that was brilliant. I really enjoyed that. I learned lots as well. I love this. It's always important to learn. We go to the Yam Festival. We've been there last couple of years. We go to university and college events. Last week we joined October's always busy because it's the Black History Month. So people are always inviting us, and they say, can we have some screening? And we go. The Black Men's Mental Health event, which was last week, and we go by invitation, word of mouth. Sometimes people will say, they'll email CAHN and saying, we've got this event. Do you want, have you got anybody who'll screen? We go. And we screen everybody. Absolutely everybody. We don't just screen over a certain age or that. In fact, the youngest we screened a 15-year-old. That was one of the first times we did it. And he was just going past and he was just being curious because he was quite a big lad who was playing basketball or something like that. And we found some abnormalities, and we had to call his parents over at the church, and he ended up being referred and getting treatment because something was found as young as that, 15. Thank you. I think I've finished now.